Good afternoon, everybody. Welcome to another episode of Asna's Runways and Roadways podcast. You've got Ryan and Shay with you this afternoon, joined by a very special guest, Lacie. Jason apologizes for not being here. He is currently celebrating his 50th birthday on a cruise. So, Lacie, if you don't mind, could you just tell us what we're going to be talking about today? Tell us a little bit about yourself and tell us something about you that you enjoy doing in your free time that is not medically related. Maybe you do to decompress after a long shift so I'll go ahead and let you take it away.
Sounds good. We are going to be talking about everyone's favorite subject, which will be high-risk OB transports or obstetric transports in general. That's my specialty and my passion. Kind of my history with the medical field is I started at a pediatric hospital a month after I graduated high school as a phlebotomist. And I stayed there for the next about 12 years of my life. So I grew up during my informative years in an incredible facility where they raised me to be a big grown-up nurse. As a nurse there, I worked my way through a couple of units. I did a general children's medical unit, the PICU, and then at some point I needed a change and ended up in labor and delivery, which was never on my agenda or radar. But after having an incredible birth experience of my own and falling in love with how those nurses took care of their patients, I transitioned into a labor and delivery nurse and realized that I loved that in a totally different way than I'd loved everything else. From there, I then became a high-risk OB transport nurse, which flying was always my hope, but I always thought I would fly as a pediatric nurse. And so I just ended up doing this in a different way than I expected. When people ask me what my favorite job has been, I really can't tell them because I've loved everything that I've done. There's just a deep passion for peds, for high-risk OB, for labor and delivery. It all has kind of a unique spot in my heart as far as my career goes. For my personal life, I have a family of 4 perfect little humans and an incredible husband who supports me in a lot of wild ideas. And anything that has to do with water is where you will find me in my spare time. A swimming pool, a lake, a stream, a large puddle. I love to be in the water. So that's my favorite thing to do when I'm not at work.
Very cool. And about how long do you think it took you to get comfortable with OB transport?
Ooh, I'm not comfortable with OB transport, and nobody should ever say that they are. Only because what you are getting is never what you might end up with in the end. So I am comfortable with my patient population, but I do like to say as a joke, like, who wants to put a mom in the back of a helicopter or an ambulance? The answer should always be nobody. It's a bad idea, right? It's a bad idea because it's scary and we don't know what they're going to do. And these moms are typically not trustworthy. But the idea of what we can do for them by getting them to definitive care at some point makes the risk worth it.
I mean, I'm not gonna lie. When it comes to the world of OB transport, I do find it rather fascinating, and I find myself constantly trying to refresh on information that has to do with the world of OB transport, just because it's not something that we frequently go out and do, at least with the program that I'm currently with right now. What do you think makes people so nervous about taking the OB patient?
I think the problem with this patient population is that the potential for things to go wrong means that you're going to have 2 patients and not 1. And that everything about pregnancy is a little bit unique and quirky. And oftentimes, if it is not your specialty, even in bigger facilities, things are missed. These women report to an ER and symptoms that they have that can be critical can be chalked up to other things. And so they're coming in and they aren't getting adequately assessed simply because our bodies change just enough to mimic other disease processes. And so it's easy to miss big signs and symptoms that these women are in trouble or in need of more help.
Lacie, before we get into certain etiologies, I think you're touching on a really good point. Is transport worth the risk to the pregnant mom? And I find this interesting because I've worked at a couple different programs, and one of them was very OB heavy. Like in orientation, we went over OB specifically with maternity specialists and midwives, and they taught us how to read the TOCO monitor, and they wanted us to be very comfortable with the high risk OB. And with the program that I'm at now, they're heavy on using an algorithm to see if we should even be transporting mom at all with a very hard cutoff. And so I think that's really interesting on at what point are we doing more help to mom or more harm to mom? Is it worth the risk for transport? I'd love for you to touch on that a little bit.
Sure. I am lucky enough to be part of a program where we are dedicated high-risk OB nurses. So we started originally as labor and delivery nurses that really worked kind of in a redeployment setting. We worked on the floor. If a call came in, then we left the unit and took these transports. And in our area, there is enough need for this that we were able to move into a dedicated position. So we are a 24 supported part of the flight team now, which is super awesome. But within our flight group, we also have neo specialists, pediatric specialists, paramedics, and our adult nurses. And so we have a huge variety of support people. And it's unique to us that when a call comes in, I get to choose who is going on a transport with me, which means that we don't have a hard cutoff. When people say to me, like, when are you not going to fly this patient? I help with our guidelines, and we don't have a rule on this. We have a lot of things to look at, but because I can take with me an adult nurse if I have a mom and help syndrome, or I can take a neo and an adult nurse if I have an actively laboring mom, so that we can support an entire group of people if the need arises. It makes it a really unique setting for us. And I recognize that not all flight programs have all of that. And I feel super lucky that we've created a program that gives us some opportunity to be flexible. So when it comes to the risk for mom, I am a huge fan of the mom being part of that equation. And our MFM group that works as our medical control is as well. So I'll talk about a few of the times that we've transported moms where people are probably going to say, I would never have imagined doing that. However, these moms are in charge of their own bodies, and they are in charge of the decisions related to these babies whenever they choose to come. So we have transported moms that are completely dilated, and we do this when the mom knows the risks of delivering and transport and our limitations on being able to really manage a baby or resuscitate a baby during transport. These transports typically happen when you have a really preterm mom that desires full resuscitation of these babies, because resuscitating a baby in a rural facility at 23 or 24 weeks is difficult at best, but more so than the actual resuscitation of that baby is transporting that baby. And that comes with an enormous amount of risk for an infant that premature. And there is study after study after study that supports how hard transport is on these extreme preemies. And so we know that if we are able to move this mom that is 23 weeks actively laboring and potentially ready to deliver to definitive care, her outcome for that baby is significantly better. So when we get a request, when they're advanced dilated, we automatically have the doctors start having the conversation with mom that we will come. We will transport if we are able to, with limitations, knowing that if a delivery happens in the back of an ambulance or a helicopter at 23 weeks, we're pretty limited. No matter how good we are at our jobs, no matter what resources we have, we are not in a hospital at that point. And so they get to have some say in how their shift looks from there. We have parents that want it, that understand that transporting that baby is really hard on the baby, and some that say we're going to say we'll deliver and then we will transport baby after that. So the risk outweighing the benefit. When we're looking at this from our perspective with the resources that we have, where I'm from, a good portion of our state is considered rural. So there is a small amount where we're within a few minutes of like a quick flight time, and that makes it a pretty easy decision. But when we're talking about a 2 or a 3 hour fixed wing flight, like those really are considerations that we weigh heavily. In those circumstances, often we're traveling as a 3-person team with an adult or a paramedic, or a pediatric nurse even, and a neonatal nurse. And we're getting to the mom, reassessing the situation at that point, and updating everybody and where we're at and whether or not it's appropriate. So our time frame is a huge thing when we're looking at this. The resources that we have are, I feel incredibly lucky for my crew members because they are excellent at their jobs. And so when we are going out, it's really a cohesive decision as to if this is appropriate or not, with our medical director being involved and mom. Does that answer it? I know it's not a black and white line, and that's probably what makes it so hard for everybody.
I think your answer is absolutely perfect. And I love how you empower the mom to be a part of the decision. That's really cool. And you mentioned flying in a rural area. I think a lot of us service rural areas, and we don't always have the luxury of having the robust team that you guys carry. And so what it really boils down to for us is it more practical to have them with the flight team that maybe has a few more resources and a little bit more training, or have them go in ground and potentially not have the flight team? I think that's kind of what empowers some of our decisions sometimes, is if we can at least get a flight team with them.
Absolutely. And I think there's something to be said. Currently, we're having a lot more across the United States. We're losing a lot of our obstetric resources. I'm sure you have seen the information as far as that goes. So we are having less high acuity hospitals for our moms and our neonates. Our delivery resources are really diminishing. And so understanding that while delivery rates in general are going down, our birth rates are going down, our high acuity patient population of moms is going up. I think there is a huge and really disturbing statistic where across the world, there's a decreasing trend in maternal mortality. However, for the United States, it's going up. And so they're really trying to figure out right now why we're having this increase where we live in the United States with all of these resources. Why is our maternal mortality going up? And I think there's so many factors that play into that. But our moms are getting sicker, and we're going to continue to need this resource for a really long time. So giving the ability for flight teams across the nation to maybe not feel comfortable, that's the wrong word, but have a better understanding of these patients so that they can feel like they can take the best care of them is wildly important right now.
Kind of rolling over into the next question, in terms of the general assessment of the OB patient, for the novice OB provider walking into the room, what are some tips and tricks that you would have for those individuals? And what are some situations to where you say to yourself, whoa, like we are not moving with this patient. We need to stay in place. We need to play here, and we need to figure out another strategy?
Absolutely. So the first thing I'm going to tell you with OB patients is you should be touching your patient. I'm never going to tell you to do a cervical exam. That's not in everybody's wheelhouse. And unless you've done them lots in your life, you're probably going to be wrong. But you should be touching these moms' bellies. If you are or ever have been friends with a labor and delivery nurse, you will recognize most of them have no bubble, and they just automatically are touching somewhere on another human being. We do that because so much of our assessment with contractions and pain and kind of what they're telling us, is it fitting what's happening in her abdomen, comes from that. So for me, going in and sitting down next to her and talking to her with my hand on her stomach is second nature. I know that is not second nature to most people, but when you are talking to her, just saying, do you mind if I feel your contractions while you're doing like your general, not the head to toe assessment, but like your look-see, where she's telling you she's an 8 out of 10 pain, but she's texting on her phone and you're not feeling anything contraction wise on her belly, which so everyone's aware, should be distinct. You can feel hard spots and soft spots on a pregnant tummy at any time, but rock hard and staying rock hard is not normal. Rock hard and then loosening, you would chalk that up to a contraction. And if that is consistent with her like stopping talking, can't breathe through it, like you're kind of associating those two things for her. So get comfortable with touching her stomach, just for the mere fact that if you touch it and she is retching in pain or moving or guarding, also not normal for a pregnant woman, and you should be concerned about other things. If your mom looks bad, your baby is bad. And so one of the big things that I think was a shift from a labor and delivery thought process to a transport process is I'm not nearly as worried about my baby anymore. In a hospital setting where you have every resource, it's easy to, as soon as something looks uncomfortable, we can change that and we can get a baby out if we need to. In a transport setting, I don't have that option, right? And so your idea is that you have to support that mom the best that you can so you can support your baby. So when you're looking at her, you're still going to do your typical head to toe assessment, but the things that you want to know, and especially if you end up like on a scene transport and you may have limited time where she is conscious, is ask what gestation she is. That seems so like obvious, but that is a huge key and is really important for the people that you hand her off to. So if something were to go really, really poorly and all of a sudden she's not conscious, you want to know what gestation she's at, if she has any medical conditions. So a lot of complicating factors these moms will know of if it's anything related to their pregnancy. So like a placenta previa, which could cause bleeding. With our assessment, you're going to continue to talk to your mom. As you are doing your head to toe, make sure you're paying attention to vital signs. If anything seems off, just ask her what her trends have been. So if she's been having any routine prenatal care, she'll know where her blood pressures have been sitting. A lot of these women end up with gestational hypertension or kind of starting down the path of pre-E. And these are all normal reasons to transport because pre-E is a quickly progressive disease. And we can talk about that in a little bit, but a lot of hospitals don't have the same resources. And especially if we're going down a path where delivery may be imminent because one of these disease processes is moving, we need to know. So if all of a sudden she's coming in, she's got a headache or upper right gastric pain, blurred vision. And when I say a headache, to be clear, I typically differentiate between a headache that goes away with Tylenol, a headache that does not go away with Tylenol. So those kind of things. And then all of a sudden she has a blood pressure that accompanies that is higher than normal. And don't get caught up in severe range blood pressures. While those are really concerning, a lot of our moms that end up with pre-E or even seizures don't have severe range pressures. They're just elevated pressures. So it doesn't have to be severe range for us to start worrying about those things. All of those, your global assessment is really important on these moms. The part that I think that makes people uncomfortable is she laboring or is she not? And is she safe? And how do I tell? And you can't. So even with all the experience of labor and delivery behind me and the ability to check her cervix for myself with an accurate, like, oh, she's a 6, she's still intact, she's having occasional contractions, I feel fine moving her, isn't a guarantee that I can get her anywhere safely. So you are maybe at a slight disadvantage not having that experience, but you have the ability to critical think and you have a global assessment, which is going to do a lot. A woman that is laboring or contracting does not necessarily mean she is going to be delivering soon. You have a million things that play into that. What number baby this is, how far along she is. All of those things also contribute to this. So having a general idea of what you're comfortable with, what your system supports is really, really important. I will say monitoring the baby in transport has advantages and disadvantages. But one of the things that each of you can do as a part of a transport team, if this is not your specialty, when you walk in, ask what the baby has been doing. And that's not to mom necessarily, that's to your staff at the hospital. So if they have any sort of labor and delivery resources, they should have made sure that heart tones look okay. And oftentimes in different facilities, they will have them on continuous monitoring, and having them say, oh, my baby's heart rate has looked okay, or we've been having decelerations, is a key factor in what you should do. If you're getting information that they've been having decelerations, you shouldn't move until you've talked to your medical control to say, hey, just so you know, they've already been having decelerations. We have a 2.5-hour flight. Do we need to deliver here because this baby is already showing signs of distress? That's an assessment that is difficult when that's not your specialty, and you really have to trust the people involved in that. And it will be a cohesive decision and some gut instinct, to be honest, on that. If you're feeling like this isn't a good situation, I don't have enough information. All of us have medical control to rely on and to help with these situations. And even if it means having somebody Doppler while you're there at the bedside to hear for yourself where those heart tones are for a couple of minutes, if they don't have other resources, so that you can say, I heard this, I can document that I had good heart tones at this point and move forward from there. So that's kind of your limitations with your fetal assessment. When we move back into the mom assessment, asking those questions as far as gestation, medical complications, any medications she's on, which may seem silly, but passing those again on to the next facility is really important for her, especially if we're going on a long transport and things change going into it, because some medications can affect baby at birth, right? And so being able to say, hey, ooh, all of a sudden she's acting really like pushy. I know that we're dropping off quick, but I want to make sure you know she is taking this because it does affect babies. So those are quick, concise things that mean something to the people that you're handing off on. Not necessarily as much for you as the transport personnel, but for the person that is going to receive that patient. Asking if she's had routine prenatal care gives you a little bit of insight into what she knows about her pregnancy. So it can help you know whether she is accurate or close to accurate on her dates. And that can be tricky. We've run into a lot of really interesting scenarios where we think that we've got a viable baby and turns out dates are different than what we were told. So there are a lot of kind of squirrely pieces to this, and taking in that information and then saying, okay, I know for sure that the last exam that was completed was last week in the office. At that point, she was fine. There was no concerns. Today, she's showing up with this weird upper gastric pain that is unusual for her. Her blood pressure seems slightly elevated. She can't remember what it used to be, but it's higher than it has been. And all of a sudden, her lab values look just a hair different than what you would expect them to. Gives you enough information to know this patient does need to be transported. And in all fairness, while she might not look critical yet, it's the best time to transport these moms. So hopefully that gives you enough information. I know it's still a very gray area, but using all of the experience that you're coming with is already giving you an upper hand on these patients. When she says she's 23 weeks and she feels like there's something between her legs and there's not an ER doctor that can do anything, you don't have to do a vaginal exam. I would never expect that, nor do I think you should if that's not it, you've not been appropriately trained. But lifting up a blanket and looking can actually give you some information. There is times where you can have bulging membranes that actually come out of the vagina and they're kind of sitting there like a water balloon. And you don't have a baby yet, but there is this kind of trailing look and you're like, this doesn't look like what I know, and I should be concerned. So kind of living in that little bit of uncomfortable zone of having to ask questions you might not normally have to ask. Having a doctor be the one in an ER that gives you a cervical exam and asking their comfort level on, do you feel pretty confident in that exam? Which is hard to question somebody, but if it's not what they do all the time, we've had doctors give us an exam that is significantly different than what we arrived to. And it's by no means a criticism of anybody. It is just, if it's not what you're doing regularly, then it's easy to mistake things.
That was absolutely fantastic. You brought up viability. In terms of weeks of gestation, and I'm sure that it varies a little bit from facility to facility, program to program, but like, what is one of the more extreme cases that you've seen, or what's the lowest weeks of gestation that you've seen have a positive outcome?
Ooh, that is such a tricky question and such an ethical one. I'm glad we're going to dive right into that. This is like second date material, just so you know. So general viability, again, you are absolutely right. There's arguments across the board on this, but for us, we say 23 weeks. However, it is based on baby's weight, and that can be based on whether they are a singleton baby or a multiple, so a twin or a triplet, or if it's called IUGR, which is they're not growing well within utero for whatever reason. So preeclamptic moms often have IUGR babies. Smoking moms have IUGR babies. Their placentas are not as healthy, and so babies don't grow as well. So even though they should be 26 weeks, their growth rate is more at a 23-week gestation. So when we get these calls and a gestation is given, especially around that 23-week mark, you're always flagged a little bit like, hey, 23 weeks, I only trust if it's an IVF baby. This mom knows exactly when implantation was, right? So let's go to the idea behind the weight of the baby and why this is so important. It comes down to oftentimes you can't intubate a baby, a premature baby, that's it's between 400 and 500 grams. And it depends again on the baby. At less than 400 grams it's usually off the table to even try to intubate. There's not equipment or tubes that really work for that gestation. And for that 400 to 500 gram range, they can be a little bit less than 23 weeks, which is a tricky situation because you say a successful outcome, and I think success is defined differently. They may be alive, but the risk factors at that gestation are really, really high, and the outcome long-term for these babies is not usually without its own deficits. So success that a baby is born alive and able to be intubated, yes, it can happen. I've seen it as low as 22 and 4, I think is the lowest I've seen. I'm sure a neo-nurse and people that work in that field have probably seen a little bit lower. Success is in the eye of the beholder.
I thought that was a really, really great answer. Thank you so much. And I mean, when it comes to babies that are that underdeveloped and young, I mean, just the intricacies associated with the care, it's just absolutely unbelievable. I mean, down to the smallest volumes of fluid to be administered. Oh, we have to be cautious with how fast we're giving these fluids because they have an immature germinal matrix and we might disrupt that and cause intracerebral hemorrhage and, noise stimulation and light stimulation. It just absolutely fascinating. So once again, thank you.
Yeah. I will say, I haven't really touched on this. When we go in our configuration, if I'm worried at all about a mom that either I think is laboring and could deliver by the time we get there, or things are changing, or I've been kind of warned that like her fetal tracing doesn't look great right now, but we still want to try and go down this path and we'll reassess when we get there. And these are all scenarios that have happened. I take a neo nurse with me. We take all of our neo equipment. So I have a brilliant human standing next to me that knows how to treat these babies. And then we take everything with the exception of the isolette. And then I take everything to take care of my mom patient, and I always bring another ACLS provider with me. So whether that is an adult, a paramedic, or a pediatric nurse to accompany me, we'll go in that 3-person team in particular on those ones, so that by the time we get to the facility, if things have changed, we can stay in that facility and assist with that delivery. We can support the mom, we can support the baby, and our isolate is then sent to us, which is a huge perk for us to be able to do it that way. If I'm not worried about a delivery, I typically don't take my neo nurse, but that is my instance where she or he is really my crutch. They are these great nurses with such an incredible skill set. And I think being able to offer that to the facility is unique, to say we can come and we can change the plan when we get there and still be at the bedside to help support you. So it's something that I really appreciate that we have to be able to do.
Before we move on to the next topic, because we've got some really good topics to cover still, I have a kind of a burning question for you, because I feel like I've heard this from a lot of different people and have had mixed reviews, and you've touched on it a little bit. We shouldn't be doing cervical checks if we're not trained, obviously. Do you think that as a flight provider, if we're going to fly OB patients, should we be trained in doing cervical checks, or because we're not doing them frequently enough, should that just be off the table?
I love the burning questions. I have an opinion and I'm going to give it to you, but that doesn't mean it's the rule, okay?
Fair.
I don't think you should be trained. I think that in all fairness, I rely on my cervical exams from years and years of labor and delivery, and not only years in labor and delivery, but years of labor and delivery in an acute setting at the highest delivering hospital in the state, where I'm doing, I mean, you can do anywhere from 10 to 20 of them easily in a shift. We're not talking about like once a shift but when you're triaging these patients and you are doing it regularly, you certainly learn things, you feel things, there's quirky things. I do not think that it's a skill that can't be learned, but I think that it is a skill that is honed over thousands of checks. And even when we're orienting new labor and delivery nurses, you're 6 to 8 months before you really start to trust those exams, which is not, it is not a discredit to them. It is simply because they are different, and every woman's body is a little bit different. How they carry babies are different. And there's discrepancies across the board with this. But in the end, when you're determining with that exam, whether you want to put someone in in a helicopter or transport them, I wouldn't want to be a determining factor unless you had years of experience behind it. Again, just my personal opinion. I am not saying that I don't think others are capable. I just think that the background of it and having those over and over and over and over for years are what make you reliable in them.
Yeah, that's a great answer. And I think like the best takeaway from that is that there's a lot of factors that we're going to use. So relying on something that maybe we don't do all the time doesn't have to be like the number one thing. Yeah.
And I will tell you, I don't check every patient that I take. So here's a couple of things that I think are important. When I get a call and we get a basic story, you guys all know exactly what I'm talking about when you get a story and then you get there and it is nothing like what you heard on the phone. So you're just kind of recreating a new story based on the information that you are now getting at the bedside with eyes on the patient, right? It's oftentimes significantly different than what you initially heard. So using those factors, I never recheck a mom if her contractions have not changed. So if when they called me was an hour ago and now I'm finally at the bedside and I say, how are these contractions? Have they gotten worse? Are they stronger? Are they getting closer together? Add those to your list of assessment questions. If they aren't getting worse, if they aren't getting stronger together, I don't recheck her cervix. I go off of what the last exam was, because the last thing that I want to do is, number one, possibly break her water if it's not already broken, or kind of, we call it stir the pot, which sounds gross, but there's labor and delivery stuff. It's all a little gross. So there's no reason for me to intervene at that point. And I can look at her monitor, and if my baby looks good and my contractions are about the same, what I want to do is move her quickly before it does change. So I typically just chart that I did not recheck her due to the fact that nothing has changed on this patient from the time I got the call, and that I'm going off of what the last provider's exam was. I recently did do a transport where the patient refused to be checked. So she refused to be checked from anyone, and she was actively contracting. And it was pretty unnerving to know that I was going to put her in a helicopter with no idea what she was doing. I knew all of my information for an assessment, so this will be how you guys feel. I knew how many weeks she was. I knew what her prenatal care was. I knew what her vital signs were doing, but I had no idea, besides watching her, how often she was contracting and what her cervix was doing. And so it was one of the transports where we had discussed beforehand that we weren't going to have the same information that we normally do. We were going to have our delivery kit close to us in the back. We were going to have everything that we needed for baby in the back, as well as the personnel that we wanted strategically placed in our helicopter, because I really didn't have any idea what I was walking into. And even though I asked again when we were there, she refused to be checked. And I am by no means going to force that. She knew that there was a chance of delivery in the helicopter or the aircraft. We had discussed what that meant for her and for her baby. We also discussed what it meant to get her to definitive care. And again, a mom advocating for herself and her baby is something to be listened to. And so I'll tell you, I don't check every patient that I take. So here's a couple of things that I think are important. When I get a call and we get a basic story, you guys all know exactly what I'm talking about when you get a story and then you get there and it is nothing like what you heard on the phone. So you're just kind of recreating a new story based on the information that you are now getting at the bedside with eyes on the patient, right? It's oftentimes significantly different than what you initially heard. So using those factors, I never recheck a mom if her contractions have not changed. So if when they called me was an hour ago and now I'm finally at the bedside and I say, how are these contractions? Have they gotten worse? Are they stronger? Are they getting closer together? Add those to your list of assessment questions. If they aren't getting worse, if they aren't getting stronger together, I don't recheck her cervix. I go off of what the last exam was, because the last thing that I want to do is, number one, possibly break her water if it's not already broken, or kind of, we call it stir the pot, which sounds gross, but there's labor and delivery stuff. It's all a little gross. There's no reason for me to intervene at that point. I can look at her monitor, and if my baby looks good and my contractions are about the same, what I want to do is move her quickly before it does change. So I typically just chart that I did not recheck her due to the fact that nothing has changed on this patient from the time I got the call, and that I'm going off of what the last provider's exam was. I recently did do a transport where the patient refused to be checked. So she refused to be checked from anyone, and she was actively contracting. And it was pretty unnerving to know that I was going to put her in a helicopter with no idea what she was doing. I knew all of my information for an assessment, so this will be how you guys feel. I knew how many weeks she was. I knew what her prenatal care was. I knew what her vital signs were doing, but I had no idea, besides watching her, how often she was contracting and what her cervix was doing. And so it was one of the transports where we had discussed beforehand that we weren't going to have the same information that we normally do. We were going to have our delivery kit close to us in the back. We were going to have everything that we needed for baby in the back, as well as the personnel that we wanted strategically placed in our helicopter, because I really didn't have any idea what I was walking into. And even though I asked again when we were there, she refused to be checked. And I am by no means going to force that. She knew that there was a chance of delivery in the helicopter or the aircraft. We had discussed what that meant for her and for her baby. We also discussed what it meant to get her to definitive care. And again, a mom advocating for herself and her baby is something to be listened to. And so documenting that she was aware of all of those things and that discussion had taken place was part of our charting. Let's talk about, we're talking about transporting obstetric moms or high-risk OB. For us, we define that as anybody, we say in our guidelines, 23 weeks through postpartum up to, I think we say 6 weeks. But a fun fact for everybody is that we really consider postpartum moms up to a year. So they can still have serious consequences from pregnancy for up to a year. We just have kind of limited ours based on a guideline with the caveat, and it says in there that any doctor can request a high-risk OB go on any patient at any gestation or at any time after that mark for their discretion. So we have actually transported a lot of pre-viable patients based on doctor request and then past that typical kind of time frame for postpartum. The reason the postpartum hemorrhage is such a big deal is they are different than your regular hemorrhaging patients. They are bleeding patients, which means our adult nurses and our paramedics are wonderful and brilliant, and they know how all of these things work. The dumb thing about us as women is that most of our postpartum hemorrhages are from uterine atony. So it's like 89% of what causes a postpartum hemorrhage is uterine atony. So fixing that means you have to have specific things, specific medications, specific interventions, and oftentimes surgery. Anything else that we do is not going to fix it. We're just buying time. So when we are transporting these patients, another benefit and blessing, so to speak, that I get to have is blood. We take 2 units of blood on any postpartum hemorrhage. We take 2 units of blood on any patient that's dilated to a 5 or greater, and 2 units of blood on any patient that has any sort of vaginal bleeding, so that we have the ability to give that. And it's easy access. We grab it and we go. With our postpartum hemorrhage patients, medications are a key factor. And I don't know what other flight companies have in their arsenal, but I will tell you things that I would fight to get. Oxytocin being the number one thing. If you can pick one postpartum hemorrhage med that you can say, we absolutely, no matter what, have to have this, choose oxytocin. Another one that is amazing to have is Methergin, tranexamic acid. Most of us carry that. And so we typically don't have to fight to get that one. We use that all the time in labor and delivery, and we should absolutely be using it on these patients. And then Cytotec or misoprostol is the other name for it. So the things with these hemorrhage meds, again, it's not going to fix an issue immediately. It will buy you time. And each of these meds work in kind of a different timeline. So some of them are going to give you a quicker effect. Some of them are going to be a little bit longer lasting effect. But when we go on these postpartum hemorrhage cases, moms are jerks, you guys. Once they start bleeding, they don't want to stop. And I brought up an actual patient that we transported. We transported her from a great facility. So another thing that I think people don't recognize is there's our bigger facilities, and then there's like our medium-sized facilities. And we're transporting oftentimes out of those medium-sized facilities. And it's because either they don't have a NICU resource, or in the case of our moms, if it's a severe like help case, they don't have an ICU that could support them. And in our hemorrhage moms, they don't have enough blood products to support them. So we get these moms that have these beautiful term deliveries. Nothing was supposed to go wrong, and everything did at the end. And there's not a lot of precursors to this. We try and recognize the moms that are going to hemorrhage. And a little fun fact or a tidbit is that a few hospital systems now have implemented postpartum hemorrhage scores. So what that means is that anytime a laboring mom or a mom comes in through a labor and delivery department, she goes through triage and gets a score. And that score is based on how many deliveries she's had, if she's had C-sections, if she has certain diagnosis, and it gives her a postpartum hemorrhage score. And in those facilities, at a certain score, they type and cross her. If she hits another marker, they automatically order blood and put it on 2 units available at all times. Because she's that much of a risk, we expect this hemorrhage to happen. Then there's the other moms. They're the moms that come in and they have a low postpartum hemorrhage score. Nobody knows this is expected and they won't stop bleeding. This case in particular was a mom that we transported, again, from a great facility. It was a moderate level hospital, really, really good labor and delivery department. And we transported her simply because they ran out of blood products. And it's a true limitation in these kind of mid-level facilities where I think growing up in a big hospital, you don't recognize how many resources you have until you start visiting other places. So once she was moved, the unique part of this is we actually had to combine teams from 2 different hospitals to get to her because we had a high-risk OB at one hospital and the partners that she needed were at another facility. So when our high-risk OB got this call, she knew that it was not a great situation and she grabbed the blood from our facility and then was flown to get her other team members and had them bring blood from their facility as well. So they had 4 units of blood for this patient instead of our typical 2. They got to her where she had already received blood at the facility, continued to transport her in a pretty dire situation. And they gave all of the blood products that we had. And then it was about 10 days later and 124 units of blood products that this mom went through. She walked out of the hospital with her baby. So a few key factors to think about with these women is they are middle-aged women, right? Young to middle age, where they are typically decently healthy, especially if they've been trying to get pregnant. A lot of women are doing the best care for themselves at that time. So when we run into these situations, if we can get to them fast and get them to definitive care fast, their outcomes typically are really, really good because they're still young, they're still fairly healthy, and with the appropriate interventions, you truly are saving their life by moving them. So as far as medications with these women, oxytocin, methergen, the tranexamic acid, and the misoprostol or Cytotec will really buy them some time. And any labor and delivery department, if you don't carry them, they have them. A lot of your ERs also have them. So if you show up to a facility and your flight company does not have these, keep in the back of your head to ask, did you give postpartum hemorrhage meds? Most of them are wonderful and will have done this very quickly. We're really proactive, based on like national standards and guidelines. Really, once we hit 1,000 mils blood loss on any mom, regardless of whether it's C-section or vaginal delivery, we are considering them a postpartum hemorrhage. And so intervention should have been done by the facility at that point. If those meds have been given there, you can re-give a second dose of tranexamic acid 30 minutes after the first dose, give her blood if you have it, and get her moved. Our high-risk OB team was approved with our medical control, and they came out and trained us on placing Bakri balloons, which if you have not heard of them or seen them, they're wonderful. There's a couple, they're intrauterine devices, and there are a few out on the market. This is the one that is approved for transport, or that we can use in transport, because the mechanism doesn't have a suction with it. So what happens with these moms is that uterine atony means their uterus is not clamping down the way that it should. You've got this huge organ that has been supporting a baby, and when all things are with birth are beautiful and magical, the baby's born, the baby skin to skin, everyone's crying, and the uterus clamps down and does what it's supposed to, no questions asked. What happens in uteronatomy is it forgets to do its job. Sometimes there's a reason, meaning like there's a little piece of placenta left in there or there's a laceration, but the atony piece of it means that it's just staying open. It's not contracting down the way that it should. Those medications will help it contract down and they will help with the bleeding. But if they are not, for some reason, we start to worry something else there's a bigger problem. So with a Bacri balloon, what we do is we actually place it. It's similar to a Foley, but with more volume to be infused. We put it up inside her uterus and then we blow it up. So you're tamponading kind of that uterus from inside. And again, this is not a fixer of problems. This is a time buyer of problems. And we transport women with these all the time because it's going to buy us enough time to get her somewhere where there's more blood, or if we need to take her into surgery, we can. Our bodies are brilliant. And so if there is a small piece of placenta left in there, it's kind of like that sliver that you have and all of a sudden your body gets all pus and tries to push it out, right? Same thing with that piece of placenta. Your body is like, oh, I don't want the placenta anymore. I've done my job. It was 9 months. I'm done. And instead it tries to flush it out with blood and they will keep bleeding until that is resolved. Sometimes resulting in a hysterectomy for these women. So
that's an amazing explanation. I appreciate that. And I appreciate explaining what a Bacri is. That's neat to know. Yeah. Absolutely. I would love to move into some preeclampsia talk. I think it's one of the most common ones we cover, flight services, and we know everybody carries magnesium, but I love to know the why and not just the what. So I would love to get into talking a little bit about preeclampsia and why we give the meds that we give.
Perfect. So preeclampsia is kind of a funny disease. They still are not 100% sure why this happens. And so it's one of those wonky processes that let's see, I have my statistic here. I think it's like 1 in 8 women, or 8% of pregnant women develop pre-E at some point in their pregnancy. So it's a high number, and it's high with us not knowing fully or understanding why exactly it happens. So there's suspicions, but nothing that is like 100%, this is why, and this is how the process works. The thing to remember with pre-E is that it moves fast. And it is very scary. So oftentimes we're watching them and you can start to see, it sounds terrible, like we refer to pregnant women as women being in the wild when they're not in the hospital. So you'll be like, oh, there's one out in the wild. Like it's just, they're not in a hospital setting. So you're kind of like watching them with one eye, but sometimes they start to get a distinct look. Even with these pre-E patients, a certain kind of edema or swelling, but their labs aren't showing it yet. Like their body hasn't caught up to the process. And so sometimes you're suspecting it, but you don't have proof of it quite yet. And with these patients, you're going to have the same signs as you would with a HELP patient just earlier. So your blurred vision, again, your upper right gastric pain, which is from the capsule that is encompassing your liver is getting swollen and uncomfortable, and that's what's causing that pain. Your blood pressures can accompany it, but they don't always accompany it. So don't rely just on that. 1 in 5 cases of pre-E happen without elevated blood pressures or protein in their urine. You're going off of these weird symptoms and then labs start to show up later. So know that there's, again, pregnant women in a gray area, it's just where they live. So you're really going to focus on a global assessment, what has been normal and what is now not normal. And so asking good questions when you're assessing them. As far as treatment for pre-E, one of the biggest things that we're all going to do is magnesium sulfate. And so the idea with our mag is it's a smooth muscle relaxant for them. You're helping to keep them, their seizure and stroke threshold lower. And we can give this even without those severe range blood pressures. We can do it when our labs are defining it, our symptoms are defining it, but we really want to be proactive in helping these women. The one thing I will tell you is we use MAG for 2 cases. And so a lot of people get a little bit confused about it. So we can give it for mom for preeclamptic, and we can give it for baby for neuroprophylaxis. When we give it for baby, we don't do it after the 32-week mark. So that's where our limitations are with that. For a preeclamptic mom, we can give it past that. There is history to MAG. It used to be used to stop contractions as well. And so sometimes when you arrive at certain facilities, they're like, oh yeah, we gave MAG to help with the contractions. And we just know like a gentle re-education is that it's not typically used for that anymore. But you do sometimes get this nice side effect of contractions slowing down or stopping while a mom is on contractions, but it is never used for that purposefully anymore. So our MAG is to kind of lower that seizure and stroke threshold for them. Our meds for preeclamptic moms are aggressive, to say the least. And sometimes people get really uncomfortable with our doses with them. So our go-to drug for a severe range pressure is labetalol with our moms. And we max our moms out at 300 of labetalol. And it is aggressive. We'll go 20 milligrams. You wait your 20 minutes, and then you're going 40, 80, 80, 80. And that is based on national standards to try and control these medications, just because we know that the higher they go, the more at risk they are. And so we really want to get them into a safer range. The one thing with these patients is sometimes we're not seeing them. They've ignored a headache for 5 days and they're now coming in because it's to the point like they can't cope anymore. So we don't know how long they've lived at these severe range pressures, if that's where they're hanging out at. And so when we start to treat them, you also don't want to drop them so fast, because baby as well has adjusted to being in this specific range. So we're really watching them as a whole. But we're going to go labetalol, then you're going to go hydralazine. And some of these moms are so sick. We've actually added into our guidelines a nicardipine drip specific for OB, because we've had so many that needed to be transported with additional support. So that is our number one to go to after we've maxed out all of our doses, to kind of support these moms and get that preeclamptic state to a safe level. We know that we're not going to fix it. We know that it's not going to go away until she delivers. We're simply going to try and maintain where she's at a safe level until we need to deliver. With our preeclamptic moms, when they get to this point where they're needing all of these interventions, typically what happens is we transport them to these higher levels of care. If they are at 34 weeks and at this state, we will deliver them. It's really not beneficial past this point, knowing that we're not going to cure this. Delivery is going to cure this, and the risk for mom staying pregnant is not worth it. However, if they're less than 34 weeks, a lot of times what we do is we get them moved. We're treating baby with steroids if possible. A MAG can double as that neuroprophylaxis if they're under the 32-week mark. And we'll try and get them through a steroid window if it's safe, so that baby has optimal outcome. But I will be honest, a lot of times they end up getting delivered because the risk to mom at this point gets really big. So, and there's several moms that we end up keeping antepartum where we do get it to a manageable range, but it's not manageable enough for them to leave a facility. And so they end up staying antepartum until delivery, where we can really keep an eye on those pressures and keep them safe, really.
So much good information. In terms of, like you mentioned, blood pressure, and obviously you don't want to drop that too fast, as you referenced a little while ago. What blood pressure parameters are you looking at, or what's acceptable for your current protocol?
Okay, for severe range pressures, we treat anything that's 160 and above or 110 and above. And it doesn't have to be both of them, it's either or. And a lot of times I will say you kind of get these mid-range pressures like 140s, 150s, over 90s, 100s. And even those, I get pretty uncomfortable. You're watching that mom really closely because at baseline, unless she is a known hypertensive patient, those are high blood pressures. And so you're not treating at that point because, again, we don't want to tank it, but really keeping an eye on those. So our hard line is 160 or 110. And again, it's either and, not both of them. To be fair, we've transported them where we're like 220 over 120, and that is with interventions, and you're just holding your breath where you get to someone that can help her more.
In terms of your mag dosing, what does that look like, and how do those patients feel when they're on the magnesium?
Oh, it's the worst. Oh, it is absolutely the worst. So I haven't been on it myself, thank goodness. However, from having to give it to so many moms over so many years, the best description that I have for anybody is it is like giving a woman the flu in 30 minutes, not the kind of flu, like full blown flu. You can literally watch them go from like pink and talking and in the bed to like everything is just heavy, hard, hot. They're flushed. They're yucky. They don't want to talk anymore. Their energy is all of a sudden just drained. It's the worst. I always preface it with, I'm sorry that I have to give this to you, but it's the right thing to do because I know how awful they're going to feel. And the first 30 minutes, if you're doing it based on recommendations, is the worst. So for mag dosing, when it comes to a preeclamptic state, we want to go a 4-gram bolus. We do ours over 30 minutes. You can technically do it over 20 minutes. But for math's sake, I do it over 30 minutes. And because it's a little bit nicer for the mom. And then after that point, you go to 2 grams an hour. And if you're doing it for neuroprophylaxis, so again, only if it's before that 32-week mark, you're going to go a 6-gram bolus over the 30 or 20 minutes, and then you'll move to the 2 grams an hour. And with that neuroprophylaxis, if you have a mom that's 28 weeks and starting down this pre-E path, you can give the 6-gram bolus because you are giving it for multiple reasons at that point. And so in your charting, you can indicate mag is being used for neuroprophylaxis and for preeclamptic treatment, and that covers you to give that dose. The first 30 minutes, you really want to watch these patients. I really try and have the facility give mag bolus before I get there, because giving that 30-gram bolus, or I'm sorry, the 4-gram bolus or the 6-gram bolus over that 30 minutes in transport is so hard on these patients. They will feel awful. So if at all possible, if you know that that's the path you're going, call ahead, see if they're able to do that as a favor to you and to the patient. During transport for these patients, for comfort for them, if they're on mag, I always give them Zofran if they have not gotten it already, because now we're putting them in, if it's summer, a horrifically hot aircraft, and they're already hot and flushed. I take ice packs with me so that we can ice pack groin, back of neck. Often your labor and delivery units have a small portable fan, and I just ask them if I can take it with me because they really feel so crummy during this time. So anything that you can do, just know as you're wrapping them up, I try and wrap minimally in my seat belts, and then we'll lay a blanket over top or a sheet over top so it's easy to remove and you're not fighting all of your belts and your tubing, being hyper aware of what they're going through with that. For your MAG assessment, ideally, if you're the one starting it, you should have a pre-assessment as well. So your big thing you want to know is reflexes, which I know sounds silly, but it's the first thing that changes with MAG toxicity. And so just knowing baseline, yeah, her reflexes are a little bit less than normal, being able to document that. So when you reassess and they are that way, you're not questioning whether she's actually MAG tox or MAG toxic.
What's the incidence been of you actually having to give calcium gluconate for somebody that is MAG toxic?
one time, and it wasn't actually my patient, it was another patient. And there was question whether it was actually a mag toxic event, but it was enough of a change in everything that that patient had had. And it actually happened prior to us getting there, but our high-risk OB arrived at the bedside shortly after she started exhibiting these symptoms. So mag is immediately turned off. If you're on mag and anything's ever in question, like all of a sudden you have a major neurological change, your reflexes are changing, first thing you do is mag goes off, no matter what. Take that out of the equation. But this had happened and they arrived shortly after that. And so between her and her adult nurse, the decision was made, we're not messing around with this, we're going to do calcium gluconate. They had physicians and pharmacy at the bedside, and everybody was in agreement that that was the appropriate intervention for this patient. So they did draw levels, but it was after that. So I don't actually time. And it wasn't actually my patient, it was another patient. And there was question whether it was actually a mag toxic event, but it was enough of a change in everything that that patient had had. And it actually happened prior to us getting there, but our high-risk OB arrived at the bedside shortly after she started exhibiting these symptoms. So mag is immediately turned off. If you're on mag and anything's ever in question, like all of a sudden you have a major neurological change, your reflexes are changing, first thing you do is mag goes off, no matter what. Take that out of the equation. But this had happened and they arrived shortly after that. And so between her and her adult nurse, the decision was made, we're not messing around with this, we're going to do calcium gluconate. They had physicians and pharmacy at the bedside, and everybody was in agreement that that was the appropriate intervention for this patient. So they did draw levels, but it was after that. So I don't actually know if that changes how it looks with the calcium already given. I don't know that answer. So it's been one time in my entire labor and delivery career, but knowing that we have it and that we have something to counteract it if we need is so important. So I think the biggest thing is knowing a baseline for the patient. If you're not the one that's able to get an assessment of her, ask if they had done that prior so that you have something to document and to support yourself during transport if anything does change.
I appreciate all that explanation. And speaking of magnesium, I also appreciate how you talked about the gentle re-education in regards to preterm labor.
Yeah.
What medication might I be expecting then as a flight clinician if I am dealing with a patient in preterm labor and they're deciding to treat?
Hey, that is an excellent question. So this is also going to be a little bit dependent on physicians. There are a few medications that we give, and in all fairness, we don't try and stop labor all that much anymore. It used to be like a normal practice for us to try and stop labor, and maybe even a belief that we could do this. We could keep women pregnant for a lot longer, which we will try and stop it in the event we're trying to get through a steroid window. But in general, right now, there's kind of the idea that if a woman is going into labor, oftentimes there's a reason why, even if we can't find it, whether there's an infection starting or something is wrong. Our bodies are really quite smart and they know what we need. So whether it's just the idea that this mom needs to support herself rather than this fetus at this point, we don't try and stop it routinely, with the exception of trying to get through that steroid window. And typically, if we do stop it, it's for a short amount of time anyway. And so we kind of go through those things. So there's a couple of options. Our first line agents are indomethacin if they're less than the 32 weeks. And if they're over 32 weeks, we go to nifedipine. And that's just because of the effect it can have on the fetus and their heart valve, the PFO. So that's where we go. We do have terbutaline as an option, but a lot of our physicians are leaning away from terbutaline for a few different reasons as far as effects on the baby. And so we are really trending more towards the indomethacin and the nifedipine. And these are all given like a few minutes apart, and then they kind of stretch out. So we will use them in transport. If it buys us time, great. If it buys us time to get through a betamethasone window, wonderful. And if by chance this mom was really contracting and all of a sudden it stops it and she maintains to a term pregnancy, that's even better. But when we utilize these medications, it's not with the hope of necessarily going to a term pregnancy. It is with the hope of a betamethasone window completed, or getting to definitive care. With your indomethacin, there's differences in dosing, and the physicians typically dictate that. It can be the 50 to 100 milligrams, and it can be repeated a few times. So in an hour, and then you move to an every 6 hour mark if you need to. And your nifedipine is your 10 milligrams, and it can be every 15 minutes for a total of 40.
Going back to just what we were talking about a little while ago, I don't mean to jump around too much, but kind of a burning question I have is, if you were to have a eclamptic patient that required intubation and post-intubation sedation, what would the preferred agent be? Would you be sticking with propofol in a situation like that because it is a little bit more neuroprotective? Or based off of your experience, what have you seen the most?
We, in full transparency, we don't transport a lot of our moms intubated that are still pregnant. Mm-hmm. The majority of our moms that have been intubated have been postpartum hemorrhages. So I don't know that answer. For pain control, for sure, we'd go fentanyl. That's what we use always.
I could see leaning that way because, you're giving a little neuroprotection, and if they're already hypertensive, then you kind of are doubling that help.
Yeah.
And that was kind of my thought. But that's a really useful tip, even with the fentanyl alone. In terms of the preeclamptic patient that does become eclamptic, I know that the priority is getting mag sulfate on board, but if you wanted to treat them with an anti-epileptic, what would the medication be of choice in that instance? What would you be going with?
So it's actually still mag. That has been shown to help with preeclamptic seizures more than anything else. And so if you already have a drip running, you're going to do 2 grams over 5 minutes for an actively seizing patient. And if that does not bring her out of it, then you can move to Ativan.
So you're giving magnesium before you're giving a benzo?
Yes.
Okay.
Yep. So, and the only benzo they really want is your Ativan. That's it. And all of this is according to ACOG's guidelines. So we are really careful that we're following the national standards. And you can give mag IM if you have to, if you don't have it already running. So back to if you have a patient with an eclamptic seizure, again, mag on the pump, you just do the 2 grams over 5 minutes. And then you'll return to your normal maintenance dose, which is your 2 grams an hour. However, if they start seizing and you do not have a mag running yet, but it's suspect of an eclamptic seizure, meaning they have any of the signs and symptoms of eclampsia or lab values that are supporting it, then you want to just do mag sulfate 5 grams IM. And you can do that. And that is still your first line. And then if that doesn't resolve it, you will move to your Ativan.
We talked a little bit about postpartum hemorrhage. Now, can we talk a little bit about bleeding in pregnancy? Is there a mentality shift that we should have? Do some of the same concepts and medications still apply? If you want to give us a little bit of insight into that, I think that's helpful. And that's something a lot of us are going to see in the transport setting as well, especially in trauma or hemorrhagic shock.
Typically, bleeding in pregnancy is not normal. In that first trimester, you can bleed for a few reasons. You can have, it's called a subchorionic hemorrhage, which those can resolve and you can still maintain a good pregnancy. Vaginal bleeding is not a thing that we see routinely without consequence. So a lot of times, if your moms have had prenatal care and they have, it's called a placenta previa, this can be one of your major causes of vaginal bleeding. And you should be wildly concerned if you hear the word placenta previa. These moms are time bombs, and they can die and their babies die. And they are scary because there's no precursor to this. they just start bleeding and they can not stop. The flip side is they can also start bleeding and then they can stop. So the definition of a previa is that the placenta has grown in a less than ideal position. So for very basic physiology, your cervix is a little tunnel, right? And your placenta can grow anywhere that it wants to. In these women's case, it grows over the top of that cervix. So when you think of a placenta, for those of you that have not had the opportunity to visualize them, think of a chuck roast. It should be nice. It should be meaty, this thick, pretty red vascular organ that is supporting human life. And it is now covering a tunnel. So as these women start to dilate, which can happen at any point during their pregnancy, it breaks all of these little blood vessels on the placenta, causing bleeding. So it causes vaginal bleeding as this happens. That's the idea behind it can start and it can stop, right? So they can have this bleeding and it can be a few pads worth, and then all of a sudden it stops and it's fine. It's kind of safely taking care of itself for the time being. A placenta previa means no matter what, this baby cannot come out vaginally. It has got to be a C-section. There's literally something covering the exit. So these women have to be delivered C-section. These are the women that our EMS crews bring us that woke up in a pool of blood in the middle of the night. And when we say a pool of blood, it's their sheets are completely covered. These moms are gray when they come in because they have bled that much. And it's because they have slowly started dilating, which is not painful unless there's contractions associated with it. And especially if they've had a baby before, not all of those contractions are that uncomfortable. And so you have these dire circumstances where this bleed is not stopping. In these cases, you can continue to give these women blood. So you're going to, again, global assessment, use all of your critical care skills. If she is symptomatic, hypotensive, shocky, you're going to treat her as such. But knowing that your interventions are, again, buying her time until you can get her to the facility where they can do a C-section, where they can deliver this baby, where they can address the bleeding. These moms that are placenta previas typically get 3 chances, and those 3 chances are dependent on how bad these bleeds are. Sometimes they come in, there's a small amount of bleeding, we watch them, they're there for a few days. If everything looks good and baby looks good, we will let them go home. But a lot of times if the bleed is bad or on their 3rd episode of bleeding, because we know how high of a risk this is for not only them, but that baby as well, we keep them in the hospital until they deliver. And sometimes that's early. They can get admitted at 28 weeks because of these bleeds and have to stay until they deliver. Again, they're episodes of bright red, painless bleeding, and they are very scary. That is your diagnosis that these moms know about. The thing you'll see more than anything, as far as related to episodes of bleeding, is abruptions or partial abruptions. And the difference with this is, again, it's associated with your placenta, but your placenta, that nice chuck roast meaty, is attached where it should. And any sort of trauma, you guys, little trauma causes huge consequences in pregnant women, and they should always be evaluated. At a small fall where she trips, she doesn't even hit her stomach, but enough of a momentum that the physics says it pulls and you go back, and then that weight of it keeps pulling. So you have this placenta that started to detach a small amount, right? These vessels at the top are starting to pull away, causing bleeding. It can be a small amount of blood. It can be a large amount of blood. It can be painful. It can be not painful. I've seen it in all of those different ways. But with women who have an abruption or a partial abruption, oftentimes they have a rigid belly. The uterus does not like blood. And so it reacts poorly. It starts contracting. It's really irritable with it. Their belly can become really rock hard and very tender. And it can also not do that. So they don't play by the same rules as everybody else. Some of them will do this and it's a classic sign, and some of them do this and it's not following any of the rules of what we're taught, but it's still by definition an abruption. With women that have these incidences, whether it's a small trip, a fender bender in the Walmart parking lot, a massive car accident where something rolled, they should always be evaluated simply because of the physics behind this. So with an abruption, it can heal itself and it can continue to a full abruption, or we call it a complete abruption. And at that point, again, mom's life is in danger, baby's life is in danger. Partial abruption, you have a little bit of a tear, it kind of heals. It's almost like a scab in utero. And oftentimes when these placentas are delivered, they tell us secrets about the pregnancy that we didn't know. So that placenta delivers and you look at it and you're like, oh, she had an abruption at some point. It's almost like a little hematoma on it, or bruised scarring on these placentas. And you're like, oh, there was an episode of trauma at some point, whether it was small or large, but that placenta healed itself or stopped its own bleeding. We put them on the monitor and observe them in labor and delivery with these instances, because as this placenta starts to tear, if it continues to pull, your first sign is not always bleeding or vaginal bleeding or pain. It's your baby. Your baby starts to decompensate because your blood flow to baby is changing. And so that decompensates, and then the uterus becomes really irritable, and we call it an abrupting pattern that is a distinct pattern that doesn't look like a typical contraction pattern. And so when we watch them in labor and delivery, those are the things we're looking for. And the idea that slowly over hours, this can continue to tear and tear and tear until you have a truly traumatic event. In trauma, if they are in a accident and you are on scene, again, this is where touching the patient is really, really pertinent. I cannot tell you over and over in studies, it says these patients will look fine, they'll tell you they're fine, and they are not fine. And part of that is because all of our physiology is a little bit quirky during pregnancy, and it's just enough with some compensation that sometimes it hides things until it's too late. So a woman can actually bleed 2 liters into her uterine cavity without showing any signs on her vital signs. 2 liters of internal bleeding that you have no idea, and she can be talking to you. So know that those vital signs are not always going to mimic what is happening. They will eventually, but kind of like a peds patient, they're fine, they're not fine. There's not a gray area for them to fall into, or they're not going to give you these slow signs. It's they're fine and they are not fine. So take into account your mechanism of injury, please. Like when you're looking at this, when you're looking at her and she was in an accident and you have a seatbelt going across her belly, think of all the things that happened that you can imagine in her abdomen that could have been smushed, squashed, physiologically torn. They're real things. And she can still be looking at you and saying she's fine for a while until she's not. So abruption is the most common one that you will see for any reason. It doesn't always mean a complete abruption. It doesn't always mean that she will deliver. It always means that she should be evaluated and looked at a high level of care facility that can intervene if they need to. For treatment, you're not going to give hemorrhage meds to a pregnant patient because we don't want to cause that uterus to start to clamp down, or then we're going to make her go into labor. The one thing that has not necessarily been studied, but we have looked at and okayed within our system is tranexamic acid. And so if she is actively bleeding and symptomatic, you want both of them, then you would give tranexamic acid. It has not been studied in pregnancy, but based on our medical control and the feelings of the risk versus benefit for a hemorrhaging mom that is still pregnant, we'll get blood, we'll support her as you would any other shocky patient. But in addition, we're saying we would give this knowing that we are symptomatic and hemorrhaging. So
that's an excellent explanation of all those different etiologies. Thank you. Unfortunately, we probably should touch on the worst case scenario and handling that, and that would be coding the mom, which obviously can happen from hemorrhagic shock and maybe a few other circumstances that you might touch on for us. What do we need to know? What do we need to think? I know talking about resuscitative hysterotomy has been really huge in education. It's not something that a lot of us are approved to do. So I'd love to hear your thoughts on what we need to know, what we need to think, and about that specifically as well.
Okay, first thing, I am going to give a plug for a new program that is out there. We have evaluated it within our system and it is absolutely incredible. It has pre-hospital and in-hospital specifics. So everybody should look into the obstetric life support system. It is truly wonderful. If nothing else, get their book off of Amazon. It has incredible information specific to this. So I would recommend that for everybody. I hope it becomes really prominent in our world because how they laid out the information and the support of these moms is unique and is needed. So let's talk about a couple of statistics before we jump into it. 80% of the deaths that happen with pregnant women are preventable. That's what they suspect. Preventable, whether it's from resources, earlier intervention, a multitude of reasons, but 80% of them are preventable. And currently in the United States, we have about 1,200 deaths a year for these women, which is a lot for a population that is generally, again, middle-aged, healthy-ish. It's just not a usual thing. And as a reiteration, that number is increasing for the United States, where everywhere else is decreasing. So we have to figure out what we need to change within our lifestyles to support these moms. I do think even bigger than that is while we have this statistic of how often these are happening, they guesstimate that for every single one of the actual maternal deaths that are documented, there are probably 100 episodes of severe maternal morbidity that almost lead to death. So then when we change that number to 100 more potentials per documented death, it's huge. So while we talk about this, just keep in mind, there's a few things that we can do. The biggest thing is we're going to talk about resuscitative C-sections, which I'm so glad they're trying to change the terminology. We used to call them, and when I started labor and delivery, I grew up with postmortem C-section, which indicates everybody's dying, right? So now we're changing it to a resuscitative C-section. And I'm going to reiterate on this. This is not to save the baby. This is to save your mom. So we know that if we can deliver that baby instantly, we are increasing that mom's blood volume by an enormous amount. And that's just because of the physiology of what happens during pregnancy. So all of a sudden, we've taken all of that increased blood volume that she has created to support this baby, and we're giving it back to her, giving her the best chance of survival that we absolutely can. So when we are going to code our patients, as far as medications, you're going to think all the same medications. There's zero changes as far as that goes. Ignore the fact that baby, yes, we'll address that in a moment, but you don't need to worry about what's safe for baby in a code situation. You're going to give mom all of the same medications. When we're doing CPR, one of your big things is left uterine displacement is not optional. We should be making that as big of a priority as good CPR because you can do the best CPR in the world. And if she is lying flat on her back with uterus compressing all of her big vessels, you're not moving the blood anywhere because there is so much weight from everything else that has been growing and acquiring in her abdomen that we've compressed everything lying flat on her back. So a left uterine displacement will change how effective your CPR is. Designating someone for that job is a big deal. In transport, we all know that's really hard if we're not traveling in a big team because you have two people, one to draw meds, one to do CPR, like who's doing airway, who's doing this displacement. But anything that you can do to maximize that is going to be huge for her. It is uncomfortable and it is hard if you're doing it well. The same way CPR is, like, you're pulling or you're pushing that abdomen truly out of the way so that you're not compressing those vessels, and doing really good CPR for her. Another big thing with these women is understanding that for the most part, they arrest in PEA. And so if they are in PEA, you can automatically start considering a resuscitative C-section. The caveat with that is that we can't do them. So if we're not trained for a C-section and we're not a doctor, we're not doing them. So knowing and being aware of where your resources are. Flying rural for anybody, I think, is hard because we know that we're long distances away from definitive care. But in the event that you had a coding mom, I would absolutely suggest knowing that if there's a hospital that has any sort of physician available, that you would be landing and trying to solicit help from that community hospital. Any doctor that does a C-section can do a resuscitative C-section. For these moms, every moment is going to count. So you're going to call ahead and you are going to say, I'm coming in, we're coding, we've been coding for this long. I need everybody in a trauma bay and we're doing a resuscitative C-section. Do not mix words. Do not let people imagine what you're thinking. Be clear and concise in what you need, and they will have everything ready for you. So walking in saying, we've been doing compressions for 15 minutes. We already know statistically our baby is not part of this equation right now. If we get anything back, who knows? But for our mom, ideally, after 4 minutes, if you have not gotten ROSC, that's when we want to do these C-sections. Transport, that's not our reality, and we all know it. So the hope is that we are advocating and watching these patients prior, knowing that we're taking them in the best case scenario. And then if something happens in transport, we are the ability to flex and be fluid and to know where our resources might be, whether that's calling dispatch and saying, find me the nearest hospital that can do a C-section and get me in touch with them. We're not going to an OR for these C-sections. They can be done in a hallway for all I care. It is a splash, a cut, and they will get that baby out to immediately get that mom that extra blood volume, and then we will deal with all of the other things on the back end of that. But they know that it significantly increases her chance of survival if we can do them that quickly. For our babies, if we are able to do this quickly, they also have a good outcome within the hospital. Our goal is always to have them out within about 10 minutes of an event that is questionable for an anoxic brain injury. They aren't our priority. It's super hard to say that. It sounds so reckless or careless, but we know our abilities to save them both is small if we're not in a hospital setting, and our ability to save mom increases if we can treat her quickly. So, questions on this?
I don't think I have anything, and I think that makes complete and total sense, and I think it's very reasonable. I mean, if you think like going to cardiac arrest, you're having chest compressions done, I mean, in the not so pregnant situation, I mean, you have probably less than 30% of your native cardiac output. So by getting baby out, I mean, massive, almost internal bolus of blood, for the lack of a better way to put it. And
yeah,
difficult thing to talk about for certain, but prioritizing saving the life of someone.
Yes,
exactly.
I do have a breakdown of how these mortality rates, where they fall. So 22% of them happen antepartum. 25% of these mortality rates come from the day up or within the first 7 days after delivery. And then 53% come from 7 days after delivery to a year postpartum. And each of them have their own reasons why they're happening. Your probably most obvious ones, your day of delivery and the 7 days after, are your postpartum hemorrhage, your embolisms, your eclampsia, and your hypertensive episodes. A really sad factor is for that 7 days up to 1 year after. A really big one that contributes to those is mental health. So some interesting things to think about.
Yeah, I appreciate you bringing those statistics up. I think we could probably have a whole episode on some of those statistics.
Yeah.
Maybe we'll have to have you back. I have a question for you if you are up to this challenge, because we have talked about a lot of things with pregnant mom and not pregnant mom, but assuming that we arrive and we are going to deliver, could you give us maybe tips for delivery?
Absolutely. Okay, for delivery, number one, use the staff that you have there. The hospital, I think probably all of us have experienced it, where you walk in, they do want to help. They want to do something, give them a job. Simple things like, can you make sure I have a warmer turned on? I need warm blankets. When a baby delivers, it doesn't really matter gestation-wise. One of your biggest things is babies really suck at multitasking. They don't like to breathe. They don't like to keep their blood sugar, and they can't eat all at once. So they can't do 3 things at once. It's so much work. So and they can't hold their temperature up. They're so needy. So you just really want to minimize what they have to do at delivery. For a really preterm baby, plastic bags are amazing for maintaining warmth. So I'm sure you've seen a Neo wrap. If you don't have that, guess what? Any bag works. So the plastic works for anything. A big biohazard bag works great. Just anything to help maintain warmth. So being prepared for delivery, I would say you are really considering gestational age is the biggest one by far, because it's going to help you know what is coming. And despite what age that baby is, all babies think of are respiratory driven. So if they come out, they're super limp, they're super floppy, they're not trying to breathe very hard, they have a low heart rate, they are respiratory driven. If you can support their airway, then most of the time their heart rate is going to start to rise. Obviously, with a really premature baby, that support's going to look different. You're going to need more interventions. But regardless of where you're at, what you're doing, know that gestation, know that you need to keep that baby warm immediately, and know that that baby is respiratory driven. So all of those things, are you guys required to do NRP?
We are, yeah.
Okay, perfect. So I would always review that if you're going on a pregnant mom, knowing that delivery is always on the table with them. It doesn't matter if we get a call and they're closed, not dilated, it's a pre-eclamptic mom. Sometimes you go and you're like, oh crap, everything's changed. So having the back of your mind, reviewing that NRP on the way into that flight is really important. You really want to support the respiratory status of that baby. So those are your 3 things specific for your baby. But use your staff. If you have great staff that seems really competent and can take care of your mom, let them take care of mom. And you guys focus on baby. That you're going to have to triage as you would anywhere. What is your sickest patient? Is this mom delivering because she's preeclamptic and going to seize at any moment? Or is she delivering because she's in preterm labor? So kind of know what you're walking into so you can have a little bit of a plan and go where you're needed most. For your mom, let delivery happen. If she's not acting pushy, you don't have to do anything. Count that as like a little bit of a grace period to be a little bit more prepared. For placenta, don't ever pull on it. That thing can stay in there. It's fine. You can transport mom with the placenta in place. Just clamp. So we always want to clamp 2 ways. I know that seems silly to bring up, but when it comes to being in an adrenaline situation, it really is one of those things that is important, because if you clamp once and cut, you're either going to let mom bleed out or baby bleed out. So 2 clamps, just remember when you get excited that that's an important thing. Most precipitous deliveries go pretty well. And I say that with a caveat because they are happening very quickly. So A lot of the times it's not about pulling or being aggressive with delivery. It's about guiding and supporting a mom through delivery for the actual delivery part. And hopefully there's staff in there to be able to assist you with that part. If by chance you're doing the delivery, just know that that's the biggest thing. Don't pull, don't grab. You're going to kind of support your perineum. You can gently bring out a leg with like a little bit of sorry, I don't know if you can see my fingers, just like a gentle under, but you're just slowly supporting and letting that baby come. You are going to want to be aware of your mom's bleeding after. For the most part, I feel like really big postpartum hemorrhages typically happen after placenta comes out. If you're having a lot of bleeding before that placenta comes out, it can be from like a laceration. Again, something we can't fix, we can't do anything about. A doctor needs to be the one to do that. And sometimes it needs to be in an OR. So you're going to watch for those things. So I gave you your 3 things for your baby. Just watch your mom. It's still going to come down to a global assessment. If you haven't been in a delivery, they're messy. It feels like a lot of blood. Use your resources, but be aware of your surroundings and the help that you have, and always call for help. There's so many options for telehealth, telemedicine, neo-docs to be able to call in to support you, to guide you, to direct you. And then keeping calm in that environment is, I would say, probably number one of anything, because it's what's going to allow you to take a moment and direct where you need to. Because regardless if there's a doctor in the room, you're wearing the uniform and they expect you to know everything. And I think that's maybe one of the hardest parts of this, is that when you walk in, even if it's not your patient population, the expectation that you're a great nurse and great at your job, and having to fill those shoes feels really big, especially if it's not where we're most comfortable. So kind of stay calm, know that you have support and resources, and you just have to be able to pull them together in that moment. So number one thing is that your 3 things for your baby: warm, dry them, respiratory, and know their gestation. That's huge. If a mom's telling you that she's going to be delivering a 22-weeker, then you can know, like, my ability to intubate this patient is probably not going to happen. And so it changes the context of that delivery. If she's going to deliver a 34-weeker, that baby is likely going to need very little support from you, a little PPV, probably, things that are really manageable from our end. It's that in-between state where you're at that 23 to 29 weeks and you're like, oh man, I wish I had a neo nurse with me. But just make those calls, use your time wisely. So I think rarely you're going to walk into a full-blown delivery. When you walk in and they're like, we think she's going to deliver quickly, say, I'm going to need some people on the phone, and have people doing that for you in the background. Like, you can be assessing, they can be calling your dispatch and getting whoever can be a support for you, especially when it comes to having a secondary patient.
Fantastic. Absolutely fantastic. So
Right, I think we have to call this episode the OB Bible.
Yeah, I think are the greatest OB podcast ever released. No, I was thinking, like, it's weird when you mentioned, babies are terrible at multitasking. I'm like, man, if I could like just put that on a wine glass and give it to like my NICU friends, then they probably would eat that up. So, I mean, if you're looking at like maybe a part-time gig or something, like maybe we could mass produce that and put it on a t-shirt. Idea. Yeah, for sure. And then just do like a little checklist of what they're bad at multitasking with on the back of the t-shirt. So
love this.
Yeah, great idea. But no, Lacie, we certainly appreciate you coming on today. It's been an absolutely fantastic experience. I know I personally have learned a ton, and I look forward to going back and listening to this episode again and then again and then again, even post-editing. So
yeah, Lacie, I want to thank you for a couple of things. One, thank you for mentioning statistics and evidence so often. That's amazing. And thank you for bringing humanity and empathy to such a sensitive topic as well. I appreciate you so much.
Well, thank you. I absolutely love my patient population. I think it's unique and amazing, and you don't get to just take care of them. You're really taking care of their whole family. And regardless, like, they are a population that touches every single person, literally. And so I just think it's really important to get our information out there. And I want everybody to have the best tools and resources to be able to take care of them. I would never want anyone to walk in feeling alone or not knowing what the basics are to be able to take care of them. So we have a running joke right now that our patients are always the easiest patients, and we like it that way. I want to transport my patient when they're still sitting up and talking to me, because it's the right time to transport them, to get them to that definitive care where we can get them in great hands in a great situation, and then we can move forward with delivery and interventions as needed. But they are a great population. I know they're a little bit scary, but this is never what they had planned. I know that's true for all transport, but in the world of obstetrics, the idea that it's beautiful and special and has always this amazing outcome is really hard when that glass bubble breaks, and the smallest touch on their shoulder and reassurance goes a long way for these patients.
Beautifully, beautifully said. I don't think I have anything else. Shay, do you have anything else? Any other questions?
No, I think you covered such good topics today. If I was going to ask anything else, it'd be about like amniotic fluid embolisms, but I feel like we're just getting off on maybe a whole nother podcast there.
We can definitely talk about those if you want to, or we can do another podcast, because that is such a hard topic and really something all its own. So
yeah, I think we'll have to have you back on.
I would love to.
Sounds good. Thanks again, Lacie.
Yeah, thank you guys.